So I think Dr. Hassel already introduced me. Thank you for having me, Dr. Hassel, here. And thank you for giving me this opportunity. I have some slides here, GI slides. I think they are very common in practice, and I think it's will be very helpful for anyone who would like to be a pathologist and start practicing. Like we see these cases almost, weekly or daily or um, whenever. So um, let's start here with the first case here. This is, let's say, it's esophagus, like it's a biopsy from esophagus. And we see here, this is squamous. We know the esophagus, like there is glands, but there is also squamous mucosa or epithelium. And this case is very common, or like it's not very common, but we see it during the practice. And like the patient sometimes can come with pain or dysphagia. And when we go here on high, then they do biopsy. Usually in endoscopy, they can see what's called ferning or sometimes whitish in the esophagus, and they biopsy the area. And then when we go high power, here we see those, red granulars cells, and those are eosinophils. And it's very straightforward and easy case to diagnose. So there is a criteria for diagnosing eosinophilic esophagitis. However, it's not like now when I see this, I am sure this is eosinophilic esophagitis because there's abundance of eosinophils, but the criteria is 15 per high power fields. However, you can still, there is some condition, you can also see some eosinophils, like GERD, but maybe it's less than this. But it can, even sometimes eosinophilic esophagitis, you might not see all this. So the thing is, when the clinician or the GI clinician, usually when they are suspicious of eosinophilic esophagitis, they take biopsies from upper esophagus and lower esophagus. And the reason they do this is to be able to differentiate between, because the differential diagnosis for eosinophilic esophagitis is GERD. GERD, you can also see some eosinophils in the squamous epithelium. So the biopsy, both the upper third and the lower third. And the reason they do this, if we see eosinophils in both the upper third and lower third, that goes with eosinophilic esophagitis. Usually the patients have allergy. There's no still well-known mechanism, but they say it's allergy or atopy, and then to food or whatever. So if we see eosinophils in both the upper and lower, that will be helpful for diagnosing eosinophilic esophagitis. GERD usually just appears at the lower segment of the esophagus. So, so that's the reason, and this is one of the cases. I've seen so many during my practice. There's nothing really. You can see also basal cell hyperplasia here. There's another minor features, so, but we hunt for eosinophils. And now we have this also this, let's say it's nodule, the patients have this nodule in the small bowel, and they did, let's say, section or whatever. And when we go here high power, we see a lot of cells, right? And if we look at it, like usually when there's, let's say there's a nodule, first we look at low power, we see the nature of the nodules and see if there's any filtration, how big it is, and then we go high power. We're trying to characterize the cells. Is it spindly? Is it epithelioid? Is it like any other? If there's, it could be also not mesenchymal tumor. It could be, schwannoma. It could be any other tumor. But here, when we look, I think that this looks more epithelioid, and it looks uniform epithelioid with abundant eosinophilic cytoplasm and some lymphocytes. And here, I brought this case because it's interesting. First is in the small bowel. Usually we see this mesenchymal tumor in the stomach, and usually most of the time it's spindly. However, I brought it because it can be epithelioid. This tumor can be epithelioid, and it can. I brought this case because to let you know it can happen everywhere in the GI. So this is small bowel, this is not stomach, and this epithelioid looking cells uniform. There's no abundance of, I don't see abundance of mitosis. There is not a lot of mitotic figure, maybe some here. So this is just arising in the small bowel. So I brought this case just like to be open-minded and think out of the box. That's even, if you don't have, if this is not stomach or small bowel and it looks like epithelioid, you should think also about GIST. You would put it in differential. GIST is one of the most common tumor in the GI, but stomach is the most common site. And GIST, like one of the factors can define the prognosis of GIST is the location. So it can, if GIST arising in the stomach is different if it's arising from the small bowel, in terms of the prognosis, or even if it's in the duodenum. Other very important factor is mitotic figures. Usually there is a cutoff point, I think less than 5 or more than 5 per 5 mm, 2 high power fields. So this, and these immunostains, for GIST, usually there's a very common one is, say, dog1, and other thing is CD117. These two are very helpful in for diagnosing GIST. So, and then let's go to the next case. So I brought this slides because it's very common in practice and everyone should know about this entity. This is, let's say, section, of colon. Female came with bloody diarrhea or abdominal pain, and they did resections because she has intolerable pain and very bloody diarrhea. So here we're gonna see, if we look here at this power, there's distortion of the crypts here. This is called distortion of the crypts, and there is abundance of inflammatory cells. I will tell you. So this, from this side, when I look at this slides from this power field, and then I see there's distortion and there is lymphoplasmacytosis. First thing I put in my mind is inflammatory bowel disease. So I will talk about inflammatory bowel disease. So inflammatory bowel disease is, in pathology, they call it chronic active colitis, or whatever the location is. And here's the thing, to be able to diagnose inflammatory bowel disease, there is features of chronicity and there is features of activity. Feature of chronicity tells you there's chronic process, and activity tells you it's still going on. Features, it's very important to know both those features. The features of chronicity, as I mentioned first, the crypt distortion is one of them, like common chronic features or chronicity features. We see here there's like crypts drop out or crypts distortion. We don't see the crypts align in organized way. Like here, this crypts, it looks like it doesn't look normal, and there's no alignment of the crypts. Let me show you if there's area where it's like normal crypts. Like here, if you compare this area, you know, in pathology, it's good to compare the normal to abnormal. So you'll be able to absorb it or like understand the features better. So here we have normal alignment of the crypts, but if we look here, it looks like there's small crypts here, and there's this distorted crypts here, and there's some area without crypts, and the alignment or like the is not well organized like normal crypts. So there's crypt architecture distortion. And this is feature of chronicity. Other features of chronicity is lymphoplasmacytosis, and this is usually happen between the muscularis mucosa and lamina propria. There is abundance of lymphocytes here and plasma cells. And it pushed the muscularis mucosa down, or you know. So here we can see here at low power, there's abundance of lymphocytes here. Other things is, I don't see it here, but you can see pyloric gland metaplasia, which is also features of chronicity, and also Pannis cell metaplasia. Pannis cell metaplasia usually happen on the left side because it's normal on the right side of the colon. So until now, this is feature of chronicity. These are all features of chronicity. Crypt distortion, architecture crypt distortion, lymphoplasmacytosis, pyloric gland metaplasia, and Pannis cell metaplasia. Now we're gonna talk about features of activity. You know, like it tells you there is still active inflammations going on. And first one is we can say there is a cryptitis. You know, cryptitis is mean inflammations of the crypts. We see neutrophils in the crypts, and like here, if we look here, there's this neutrophils in the epithelium of the crypts. You know, this is called cryptitis. This is features of activity. It tells you there's active process going on. Other features of activity is crypt abscess. We see the crypt abscess collection of neutrophils in the lumen of the crypt. It's different than cryptitis. Cryptitis usually the neutrophils attacking the epithelium, but in the crypt abscess we see collection of active inflammatory cells, eosinophils, and neutrophils in the lumen of the crypts. So those two features are features of activities. That's why we call the whole term of any inflammatory bowel disease is chronic active colitis. However, these features like chronicity and activity, if we see it, we diagnose the case as inflammatory bowel disease, but still we cannot tell if it's ulcerative colitis or Crohn's disease. But it gives us differential. However, sometimes it's hard to, you know, pathologically also diagnose if it's ulcerative, but or Crohn's disease, but there are some features can help you to differentiate. First thing is to diagnose ulcerative colitis usually is superficial, or it doesn't involve the whole thickness of the colon. It's not transmural. It happens superficially. Like here, if we looked here, we can see the inflammatory cells involving the lamina propria or the epithelium, and then the submucosa here, but it never goes down to muscularis propria or, you know, subserosa. Ulcerative colitis is involving the mucosa and submucosa. Different than Crohn's disease, usually we're gonna see the inflammatory cells goes deep. It's transmural. Like this collection of inflammatory cells, usually you're gonna see it goes submucosa and even goes to the muscle. So these features help tell you this is ulcerative colitis. Here, I don't see any inflammatory cells here. It's all here, you know. Um, Definitely you will see creep distortion in Crohn's disease. You could see everything, but you're gonna see more inflammatory cells going down. Other thing, usually ulcerative colitis, it's there is no skip lesions. You know, usually it happens in one area and or like in area, and there's no skip lesions. In Crohn's disease with skip lesion, we can see um, like distorted area, and then we see normal area, and then we see again unhealthy epithelium. So these are features, and other things. The Crohn's happen anywhere from the mouth until the anus, but like for ulcerative colitis, it's usually both the rectum or the colon. Um, uh, gonna talk. Yeah, and then I'm gonna talk about now. I brought also, so this case of this is ulcerative colitis case. I brought also case of Crohn's disease. Let's show you here. To be able to tell the difference. So this case is patients also came with abdominal pain or whatever. We're gonna look for, as I mentioned, we will still look for there's here some crypt distortion. So this crypt doesn't look normal. It's not like circular, or whatever. And there is also here, this is crypt abscess. So this feature of activity. So here we can see a feature of chronicity and feature of activity. There's here lymphoplasmacytosis. This is also features of activity. There's maybe here another like crypt abscess. There's uh, maybe cryptitis here. So I know now this is inflammatory bowel disease. Until now, I still didn't tell if it's Crohn's or ulcerative. But if we look here, uh, we see the inflammatory cells goes down to the even muscularis propria. Like you see, those are all inflammatory cells. It's different than the previous case. We see here inflammatory cells goes down even submucous and even goes to the muscularis. It can even goes like serosa. Usually they call it transmural inflammation. So this is a very good feature, like or like a difference that can help you to differentiate. Like we can compare, right? Look at this. There's no inflammatory cells here, but here there's inflammatory cells goes deep to the muscularis propria. So let's say this. So other thing is there is something called that helps you to tell this is a Crohn's disease. There's what is called deep fissure ulcer. This causes deep fissure ulcer. There's ulcer here. Ulcer, we know that there is discontinuous of the normal epithelium, and it goes deep like here. And this deep fissure ulcer can goes even deeper, even like penetrate the whole thickness of the colon or the bowel, and then make a fistula. That's why Crohn's people tends to have fistula more often than ulcerative colitis people. Other features, I might not see it here very well, but granuloma, like you can see if there is a granuloma usually happens in Crohn's disease more than ulcerative. But however, it's not very specific. It's still ulcerative people can develop granuloma, but we favor Crohn's disease if we see a lot of granulomas. Maybe there's some here. There's no one here. So these are like these two features, granuloma and deep fissure ulcers. It happens more in Crohn's disease. However, other like usually pathologists, when they in the biopsy usually it's hard, because you're not gonna see like a lot of tissue representing the entity. But in section, usually if there is a resection, um, usually it's easy to tell, but most of the time, like we can say, inflammatory bowel disease favor Crohn's disease or favor ulcerative colitis, and then they also have to correlate. But these are very important, and very high yield topics that everyone should know, and should like you will see definitely if you start when you start practicing, you will see few like cases about inflammatory bowel disease. So now we're gonna come back again to this. Let's say these patients come with esophageal nodule or mass, and they took they resected the nodules, and we see here there is a well circumscribed, mass here beneath the esophageal squamous mucosa, and then it looks benign to me. And then when we go higher power here, so looks also uniform. It looks benign to me, Then trying to tell the features, there is a lot of granular cytoplasm, eosinophilic cytoplasm, and this is very common also, or like very well known tumor or entity. And here we can see here these are granular cytoplasm, with pyknotic nuclei, round nuclei, and this is called granular cell tumor, and it's common in esophagus. However, it's the most common site is the tongue for this tumor. Usually it's arise from Schwann cells, so it's positive for S100 and also can be positive for CD68. It's a benign tumor, it's common in GI, but usually involve the tongue or the esophagus. It's benign, it's especially here, we don't see a lot of, you don't see malignant features or, mitosis or whatever. So it's other mesenchymal tumor also, and it's very important to know, and it's very high yield. Okay, let's see here. And now I brought this one to I brought some mesenchymal tumors also to differentiate between these two. So we now talked about GIST, and we talk now about granular cell tumor. Other things here that's also common, or it's very important to know about. Here we can see there is a on this this is, let's say, it's from it's colon or whatever, and we found this area here. It looks spindly too, however it doesn't form mass, but it looks spindly. And then if we go high power here, there is some cellular area and some hypocellular areas. There's like palisading of the nuclei here, and there is also we can see here hypercellular area. And then we did S100 and it came back positive. So this is, they call it Schwann cell hamartoma. I don't think this is schwannoma, as they call it Schwann cell hamartoma more, because usually schwannoma usually it should form a mass, but still some people they call it like schwannoma. I don't believe, I think it's better to say Schwann cell hamartoma. It doesn't form a mass, it happens in the lamina propria. However, it has the feature of schwannoma, like you're gonna see hypercellular Antony A area and hypercellular Antony B area. and you do S100s, and it will be positive. So, so this is also a common entity. Say it can happen also as a part of the syndrome, like neurofibroma, you know, neurofibromatosis. I mean, or type 2 tumors, type 2, and some people in the differential diagnosis of Schwann cell hamartoma or even schwannoma, it's neurofibroma, but we know like schwannoma is S100 is strongly positive. Usually, neurofibroma, it's weakly positive, or it could not be positive at all. So that can help you to differentiate between those two entities. Okay, and then let's go to the second key here. So here I will bring this case. It's let's say this is the stomach biopsy, but it can happen also in the colon. I also like brought these slides because also to tell you these entities can happen anywhere. It's very common in the colon, but it can happen also in the stomach. Like we see here, this stomach, we have like, foveolar epithelium and, you know, like, yeah, here this antral mucosa. And then we see here, if we see here, and then they do, let's say patient has abdominal pain or vomiting, and then they do EGD, and then they found normal stomach, but they did biopsy. And when we look at here, there's some, subepithelium collagen density here. And even if we do trichrome, it highlights this density here, subepithelium. And that's called, and you can see some inflammatory cells. You can see the collagen even goes down, destroys the glands, here also. This is called collagenous gastritis. It's the same one that's happening in the colon. In the colon, we call this collagenous colitis. And it can happen everywhere, and usually it's common in the colon. The most important, like, what you need to know is this collagenous colitis is part of, or it's type of microscopic colitis, or gastritis, whatever the place is. So usually the patients came, let's say, if the patient has microscopic colitis, usually the patients came with diarrhea or whatever, and then they do colonoscopy and they see normal colon or normal mucosa. So that's why they call it microscopic. Like endoscopically, you don't see any abnormality. We just see it in the microscope. And there's two types of microscopic colitis. There's lymphocytic colitis and there's collagenous colitis. This one is collagenous colitis. We see abundance of collagen. Lymphocytic colitis is more common. In lymphocytic colitis, you should see abundance of lymphocytes in the epithelium, like intraepithelium lymphocytosis. You see abundance of lymphocytes, and usually there's a criteria also. They say like 20/10 enterocytes, but usually no one uses it as long as you see a lot of lymphocytes in the epithelium. It's lymphocytic colitis. So it happens because of so many reasons. It can be because of medications, autoimmune. There are so many reasons can cause microscopic colitis, but very important to know, it's the colon has to be abnormal. If there's any abnormality in the colon, you should think about something else. So and we say there is collagenous. You can do trichrome to highlight these collagens in the subepithelium, and usually it's thick. Like sometimes you can be careful. You should be careful not to, because sometimes the normal, you can see normal little bit of collagen or like pinky area, just don't call this collagenous colitis. You should feel very thick, and you should do trichrome to diagnose collagenous colitis. And then let's do the next case. Yeah, so this one is this one now, I think it's easy case, it's like a break case, I'm sure if anyone here, like, been to pathology, will be able to know this, So this here, we can see at low power, there's dark blue, glands. It doesn't look like normal glands, This is a polyp, okay, and they took the polyp out. And then we see here, if we go at high power, we can see there's, pseudo stratifications, or like stratification of the crypts, and or make spindle or pencil-like cells. And however, it's still like located in the bezel of the crypts, So this is what calls like adenoma, right? If we just see this tubular adenoma, but then look here, there is here some also maybe some villi here, like these are villi, So this is called tubulovillous adenoma. It's not tubular, it's tubulovillous, because we have also villous components. So tubulovillous adenoma, we should see two components: the villous component, and we see the, like here also, this is villous component, and then we see tubular component here. And so they still, like they say, there's a criteria, how percentage of villous component you should see to call it. There's also villous adenoma. So they say if you see a lot of villous component, like 80%, you call it villous. But it's still people, there's also subjectivity in this, and especially if it's biopsy, you might not see the whole polyp, so you're just gonna go tubulovillous adenoma. And tubulovillous adenoma is pre-cancer. However, villous adenoma usually has worse prognosis than tubulovillous. So the best prognosis is tubular adenoma. So you go in this order. Tubular adenoma has the best prognosis, and then tubulovillous has worse prognosis, and then villous has the worst prognosis between all those three. So I'm sure everyone in practice will see tubular adenoma or tubulovillous, at least, if you, daily, or, maybe every day you see this, especially tubular adenoma. And then here we can discuss now this case. So this also sections here, it's common and very important to know about. Here we can see there's this, ulcer here. There's discontinuation, or there's top of this, like fibrin purulent exudate here, or ulcer in the top of the colonic mucosa, and that's what it calls pseudomembranous colitis. Usually grossly, or you're gonna see like a membrane, like yellow granular membrane attached to the mucosa. And here, this case also have another very nice finding. This is called K-exhalate crystals. It can cause also mucosal injury. And usually it happens, it's like people who's taking pills. It's called, I think, polystyrene. It's pills used for lowering potassium, and it can cause, there is some crystals in the pills can cause mucosal injury. It's called K-exhalate. And usually it's bright purple color like this. There's other also pills, like there's other also crystal associated with pills-induced colitis, like savilamir, and or also for biosequestrant medications. But this is also very common or like it's not very common, but it's very important to know about. It's called K-xylate. And we have here pseudomembranous colitis. Pseudomembranous colitis usually happen, because of C. diff, patients using antibiotics for a long time, like clindamycin, and it kills the normal flora of the GI, and then it helps other bacteria to grow and cause injury. And then this another type of polyp, in the small bowel. We see a lot of low power. There is, there's arborizing of the smooth muscles, or tree-like growth of the smooth muscles here. And then we see this abundant hyperplastic, glands, and that's called Butt-Jagger polyp. It's also important to know about very important features or helpful features. We see this tree-like growth or uprising of the smooth muscles. It's tree-like, right? It looks like tree. And it happens, it can happen as part of syndrome, or, usually it happens as part of syndrome. And very important is to know that there is a very common mutation associated with Butt-Jagger. It's called STK11. STK11. It's also it's like you like I've seen some or couple of Butt-Jagger polyp, and this mutation is very important. This slide also, this another common mesenchymal, tumor, or that also can happen in the GI. And let's see here. We see also here, usually it's a rise in the either muscularis mucosa or muscularis propria. We can see here, there's, when we look at low power, we see there's abnormality. We cannot have this, like size of mass, even if it's muscularis propria, it should be, as like, thinner thickness than this. And then when we go higher power, to see the nature of the cells, we see here there's intersecting fascicles of, blind spindly cells, and there's no mitosis. It looks like some of has tapered ends. So this is very common also in GI, and this is called this is leiomyoma, actually arising, in the GI, So like here, it's in the GI, in the stomach. This one, it can happen. However, leiomyoma is more common in the esophagus. But we can see here, when you go high powers, there's eosinophilic intersecting fascicles of spindle cells, and then eosinophilic cytoplasm. So this also very common mesenchymal tumor. So now we talked about GIST, granular cell tumor, and leiomyoma. Those three can happen anywhere. However, there's like this leiomyoma is more common also in the esophagus, than stomach or anywhere else. But it can happen anywhere. Granular cell tumor is more common most common in the tongue, but it can happen everywhere. And just most common in the stomach. So it's good to know, where is what's the most common location. So you put it on your mind, or put it in differential in the beginning. So those are the slides. I brought the most common or easy stuff, but maybe if next time I'll try to bring more, some challenging cases as well. But I brought these cases because I feel it's important to know about, and it's high yield and it's more common than other entities. But thank you for listening, and I hope you guys learned something today.
Walid, very good. Thank you for bringing these, bread and butter cases. We all need to see examples and there's great value in that as well. We had a good question from Mark about how to differentiate collagenous colitis or gastritis or whatever from just an aberration of tangential sectioning. So what clues do you use in that setting to guide that?
Yeah, that's a good question. As I said, yeah, tangential cutting can let you think the collagens like below the epithelium looks like a collagenous colitis. However, you're gonna see some destruction. Usually, the collagenous colitis, the collagen will goes down, not just epithelium, and can destruct the crypts. Usually, you're not gonna see. You can also see some inflammatory cells in the collagenous colitis. Like intraepithelium. So, and it's better to do trichrome to see the thickness. It should be very well, like thick, layer of collagens. And that's usually happening with practice. But I think there's something called, I can't remember, but Kindle shape collagen. Usually you see the collagen goes down, in the collagenous colitis, goes down deep to between the crypts and can even destruct the crypts.
Yeah, I would agree. I think the surface epithelial changes are the things that I always clue in on first. And if I don't have those, then I'm very reluctant to call collagenous colitis or microscopic colitis.
I see other questions. There's another question: how to differentiate severe GERD from eosinophilic esophagitis if you have got only lower esophagus? Yeah, that's usually so. That's why the good clinician GI usually, when they biopsy the upper GI, the upper esophagus and the lower esophagus to tell the difference. It's hard to tell, if there's very severe GERD, but usually also you can correlate. Usually there is also endoscopic finding in eosinophilic esophagitis. You may see farinating or ring shape, in the endoscopy. But yeah, the best thing is to biopsy the upper esophagus and the lower esophagus.
So, what about the approach of just biopsying the upper esophagus? Do you think that if they just biopsied the upper esophagus and had a excess eosinophil count there, that you could just make that diagnosis?
Well, I mean, that will be. I would go more with eosinophilic esophagitis. Usually, GERD doesn't happen in the lower. In the GERD is not gonna. I don't think it can happen in the upper esophagus. Usually it involves the lower esophagus. That's why the clinician, they biopsy both. Like upper and lower to tell the difference. But yeah, if we found just eosinophils in the upper esophagus, it will make it easier to us.
Well, very good. Any other good questions from our participants? Obviously, if you have things that come to mind later, don't hesitate to reach out to me and so forth. We'll post the video recording of this later today, and also with that, we'll probably post some additional links for the future. Just to alert you, we will have a session in December, and it will be kind of a pre-Christmas session, so maybe the last thing before your holiday weekend on the 22nd, and we look forward to a session there. Give you something to open on Christmas morning or something like that if you want to delay your watching. But nevertheless, we're very grateful for you, Dr. Ali, for sharing your cases today. And we will look forward to further opportunities to bring you back for more esoteric and challenging cases, maybe a little bit off the beaten path. But in any event, we appreciate your participation. Thank you, everyone, and that will do it for today.
Thanks.